Dr.Seebacher, an orthopedic surgeon practicing with the Hudson Valley Bone and Joint Surgeons in Hawthorne, New York, and operating at Phelps Memorial Hospital in Tarrytown. Our program, Topics in Health in the Hudson Valley, is today going to focus on subjects regarding physical therapy, physical therapists, exercise, and their role in sickness, in wellness, and how they fit and work in the traditional medical setting. Today we have with us as a guest Dr. Richard Giordano. Welcome, Richard.
Thank you, Dr. Seebacher. It's nice to be here this morning.
My favorite physical therapist, whom I've worked together with now for 30 years.
Fast amount of time. 30 years kind of goes fast when you're enjoying yourself and enjoying a good professional relationship.
Before we go further, Richard, tell us a little bit about the degrees and training of a standard physical therapist.
Since I've been a physical therapist since 1971, has evolved significantly in terms of the educational requirements to become a physical therapist, to sit for a licensing in New York State. It used to be a bachelor's degree.
That included college, in other words.
Yeah.
It was college.
No, that was college. You graduated and your major was physical therapy. So it was 2 years basic sciences, and then two and a half, 3 years was pretty much specializing in physical therapy. Of that 3 years, 1 year was an internship as part of being able to sit for the state licensing exam, and this was in the 70s.
So not every college, of course, offers that.
Now, all of the schools are accredited by the American Physical Therapy Association and approved by each individual state Department of Education that would certify that they meet the requirements necessary to sit for their various state licensing exams.
I guess physical therapy used to be something that was set up by each hospital and each doctor's office and then became licensed and accredited sometime in the, 50s?
The unfortunate World War II and then the polio epidemic kind of spurred the physical therapy profession, which grew out of nursing maybe in the 1920s, 1930s. And a lot of the returning servicemen were injured, of course, as you can imagine, and required help to get back to functioning normally. With the advent of polio, many of the children required lots of rehabilitation to get back to their normal functioning as well, and physical therapy developed a specialty.
Now, you opened up shop here in North Tarrytown, actually in Tarrytown, in the mid-70s?
Originally, when I came up, I did my first employment was at New York University Medical Center from 1970 to 1973, and then I came to Tarrytown, Phelps Memorial Hospital, and I was the director of physical therapy there from 1973 to 1977, and then I opened up my own practice in 1977 in Tarrytown, and since then we've expanded. We have 3 offices, one now in Sleepy Hollow, one in Hawthorne, and one in Yonkers.
All conveniently clustered around our practice. And I should just say to the audience that in many cases, physical therapists work for hospitals or for orthopedic surgeons, but Richard and I have always worked together as separate but equal practitioners, referring patients back and forth just based on our mutual satisfaction with the work we do. Richard, you realized pretty early on, back while you were chief at Phelps, that you wanted a higher degree than just a bachelor's in physical therapy. You went on and got a master's degree.
Yeah, as physical therapy evolved, the educational requirements also evolved and became a master's degree, was a requirement for the state exam in the 80s, for which I went back and received my master's degree from NYU. And now in the year 2020, it's now that all physical therapists graduating will be required to get a doctorate in physical therapy. Of course, many of the schools have jumped the gun on that, and now they all provide the opportunity for their students to get a doctorate degree in physical therapy. I went back and got my doctorate at Massachusetts General Hospital, and I graduated at Harvard. This was back in 1996.
You had to learn all the pharmacologic products and drugs that are commonly taken by patients and how that would affect their health as you were treating them as a therapist. Today, I guess then someone coming out of high school would go into 4 years of college and then 2 more years to become a doctorate?
Well, it's basically 7 years. So when a student graduates from high school, they can take basic sciences for 4 years, and then if they choose to go to a doctorate program in physical therapy, that's one route. And the second route is the students can make their decision early on if they know for sure that they want to become a physical therapist and commit themselves to a 7-year program at particular schools. The schools realize that a youngster making up their mind what to do for the rest of their life is very difficult. So what they do is they insist that the students intern for 100 hours before they can apply for physical therapy school, so that they're positive that this is the direction that they want to go. There are many aspects to physical therapy. I'm particularly involved in orthopedic and sports physical therapy, but there's pediatric physical therapy, there's respiratory physical therapy, there's chest physical therapy, there's
geriatric therapy, hand therapy.
Vestibular physical therapy, and so there's many specialties. So.
Right. I believe, and I know that you do as well, that patients who are in physical therapy should have a physician who is aware of the fact that they're in physical therapy. The therapist and the physician work as partners in helping the patient to achieve some particular goal, be it restoration of strength or endurance or recovering after an injury or after an illness.
We've evolved not only in terms of education, but in terms of how we can, how the patient can access us. And so it was prescription. Then it became a referral from a physician with no recommendation in terms of the treatment. And I'm just talking about the state law requirements. And now the patient can access physical therapy directly. That's in terms of the law. In terms of the care of the patient, physical therapist is really part of the medical team. And I think most physical therapists realize that, and most physicians realize that as well, is that there's only one small component. It's a musculoskeletal component. So if a physical therapist evaluates the patient, it behooves them to refer to the physician who sees the broader medical picture, so that they may consult, and so that whatever treatment plan is laid out is that it has the best patient's interests at heart.
As we design a regimen for a person, say someone who comes to my office who's 75 or 80, their knees are aching, they're hunching forward, maybe they've stumbled or fallen, or their family or relatives have said, you're not getting around as well, go see the doctor, you have these aches and pains. And so I might then send you a letter, and I certainly in the last few years have gotten away from just 1 or 2 line prescriptions, rather trying to include you as far as knowing everything that I know about that patient. And I know you've always availed yourself to get as much information as you could, and from there build a therapy project. Because clearly if someone has, say, a bad back, and you're trying to strengthen the muscles in their thighs or buttocks as far as their hips or knees, if you're doing exercises that would stress or strain their back and make their back sore, you're not going to help them. So we have to customize each regimen based on the total complex of what it is that is hindering or hurting or helping a patient, and focus on regaining strength and function and mobility and balance without irritating any of their trouble spots.
Communication is the key to this, and communicating with the physicians in terms of what the evaluation is, and then kind of corroborating as to the treatment plan always is the best issue. So the constant communication between the physician and the physical therapist is extremely important.
I know in the early sessions of evaluating a new patient, you produce a complete evaluation and a plan and a report which comes back to the physician, who then signs it and sends it back to you.
Having the physician sign it just indicates that the physician has received it and read it. But the important thing about the evaluation is that the physician is aware of what we feel are the major restrictions in mobility or strength, that he may not have spent as much detailed time evaluating small little things that we find contribute to the problem. The patient is often involved in the evaluation in terms of setting goals and what they wish to accomplish, and this is all discussed with the physician before we implement the treatment program.
So I think in essence, in the best of all possible worlds, you have 2 minds, each trained from a slightly different perspective, focusing on that patient, and each entering data and recommendations and ideas, comparing them.
2 people talk about from the patient from a different point of view, you always wind up with a much better plan.
Why don't you just mention briefly for the audience the difference between physical therapy and occupational therapy?
We have occupational therapists in our practice. He's specialized in hand therapy. There's many specialties within the area of rehabilitation. Physical therapists and occupational therapists can specialize in hands. What you were talking about in terms of A.D.L. and function,
A.D.L. is
activities of daily living, which include all the things that you mentioned, which were driving a car, up and down stairs, cooking in the kitchen, bathroom activities.
Or even the presence or absence of a sick spouse at home.
Oh, absolutely. There's an interchange between the OT, the occupational therapist, and the physical therapist, and again, the physician, in evolving a plan that's going to best benefit the patient.
We like our patients to come to the therapist's office. That's why Richard has 3 different ones. They're all centered near where our offices are and make it ideally convenient for the patients to get there and then go through the drills.
Oh, I agree with you 100% with home therapy versus outpatient therapy. The whole idea of rehabilitation is to integrate the patient back into the community and provide them with the mobility to allow them to get into the community. So if they were to stay home, they would have a tendency to pull back in terms of pushing themselves to gain that mobility. Mobility is more than getting, as you know, just the range of motion or movement in their joints and strength back. It's more of a psychological balance, coordination in terms of fear of getting out. Are they going to fall? Are they going to be able to do various things? And so, yeah, it's very important that the patients start to get out of the house and get back into some type of rehab program. I agree with you 100%. We have 7 physical therapists in the practice, and one of them specializes in pediatrics. So we see infants, 1 month old, and then, of course, all the way up to, 100-year-old people. So the gamut is large, and so we do see various types. We see neurological problems, we see orthopedic problems, we see specialized in sports problems.
Patients after strokes.
Oh, absolutely. Neurological component to mobility is extremely important, as well as the musculoskeletal component.
Right. Patients with weak legs after pinched nerves.
Patients with neck and back issues as well, post-surgical patients, whether it's knee surgery, total knee replacement, total hip replacements, shoulder, rotator cuff surgery. We see a lot of patients the first day, second day, a week after their surgery get started on mobility. Mobility is the key to regaining function in life.
Certainly people are living longer. They are staying much more active during the bulk of their lifetime. People are playing tennis and golf and skiing well into the 9th decades now, and oftentimes it's because of the good efforts of orthopedic surgeons and physical therapists, or cardiologists and physical therapists, or neurologists and physical therapists. So all these different medical specialists depend on having a person like you cognizant of all the aspects of the neuromusculoskeletal system.
Oftentimes, patients will come to the office and want to be reevaluated. For some reason, they don't want to go to their physician. They really don't feel that their musculoskeletal problem is much and they need some advice. And the patients will come into our office and we'll evaluate them, and we frequently know our limitations in terms of our evaluation and will refer to the appropriate specialist, whether we think it's a neurological problem or there needs to be further investigation in terms of orthopedic issues or whatever avenue that we think that the patient may need help. If the patient is just requires some musculoskeletal training, then we'll do some visits with them, set out a program, contact their physician, tell them what we're doing with the patient, and so that we keep everybody in the loop regardless.
One of the patients I've sent him after surgery, say a knee replacement, comes in one morning and their wound, the surgical wound doesn't look right, or if one of their legs is very swollen, more than he would expect, he's going to call me. And most of the time, I will either walk next door into his office or arrange to have the patient come over to my office, and 9 times out of 10, his observations lead to some specific modification and treatment.
We're very sensitive to various medical issues, and aside from what they show up with our office for us to take care of, whether it's a shoulder or a knee or a back. If there are other medical issues going on and we feel that the patient is not interacting correctly at the time, we'll be sensitive in terms of evaluating. We're not going to jump the gun so much. We'll do an evaluation, but we certainly will consult with the physician, either by telephone or walking next door or email, or in some situation we'll contact the physician that day and make sure that whatever we feel is a problem, that the physician is aware of it, and if they feel they need to evaluate, we'll have the patient go to them and have the physician.
Now, I know certainly Richard and I always think of ourselves as being members of a team, all working together to, I use the word optimize, meaning to get the patient in the best possible shape.
Well, we have several modalities that we address for pain reduction and edema reducing. Certainly heat and cold, but and electrical stimulation and ultrasound. And lately we have what's called a class 4 laser. As class 4 laser is a light interaction with the body cell that works on a physiological response in terms of reducing pain and reducing inflammation. It's significant. Its results have been excellent, and combined with exercise and stretching, the laser has made a big difference in lots of people's recovery. Yeah.
Let's just go back for a minute, Richard. So ultrasound you mentioned, basically that's an energy wave, sound wave.
It's a sound wave that produces mechanical vibration of the tissues, which creates heat in the body and increased circulation and promotes healing in a particular area.
Right. By increasing circulation, muscles are stimulated to grow and repair themselves.
Absolutely.
And you also mentioned high voltage stimulation.
Yeah, electrical stimulation, which blocks out, has a tendency to block out pain. Back with acupuncture, there are the competing impulses into the brain sensors of pain, and the electrical stimulation is one of those modalities that helps reduce pain.
If you fall on the playground, you strike your knee, you're lying there, you're a little child, and you reach down with your hands and you rub the skin on your knee. And that, in effect, sends extra stimuli to the brain from the bruised or hurt area and crowds the gate or the final pathway into the brain with extra stimulation, which is sort of the same idea of putting liniment on skin, whether it's hot pepper cream or wintergreen, or putting even a neoprene or a elastic sleeve around someone's leg. People say, this makes my knee feel better.
It actually does. You're absolutely right. It's the cutaneous stimulation of that compression of the rubber that is shown in studies to have really helped people feel better and perform better. But you were alluding to massage when the child fell on the ground. Massage is a modality that we use in physical therapy as well. You know, it's all about reducing swelling, reducing inflammation, reducing pain, and creating mobility. You have to first create mobility, then you need to create strength. So along with those lines, you use whatever you can.
I know, even though you don't look it, that you're actually older than me.
I am, significantly.
But I remember when you used to go to the barber had this funny little machine with springs around his hand, and he would rub it on your body while it vibrated his hand. And people used to stand up against a belt around their waist that shook them.
Well, there's good massage, and then there's gimmick massage, and I have a feeling that some of those things, massage is just one small thing. You can't shake, you can shake until your head falls off, and you're not going to reduce any weight. So those rubber belts, although they were great, Jack LaLanne I think was the beginning of.
But massage actually can loosen scar tissue. Can increase the circulation into muscles that you're focusing on.
Absolutely. And
can also, you can actually massage at the muscle insertion or origin, particularly, say, on the side of the elbow where muscles are ripping loose to produce what's called the tennis elbow. By massaging in that critical area, you can stimulate increased blood flow and healing.
Creating more thickness in the tendon or in where the muscle junction is. Massage helps reduce swelling, significantly edema in the ankle or the hand. So massage is a significant modality.
Now you also have lots of different strengthening machines, the kinds that people might see in a gym.
Well, the machine is not the answer. Certainly the instruction is the answer in terms of machines. You can get stronger using rubber bands. You can get stronger with any types of resistance. it may not be ready to do strengthening in terms of resistance.
These are all the enhanced techniques that a trained therapist can bring to bear and thus to make exercise therapy much more effective. I find myself that at times it takes a little persuasion on my part to get people to go see the physical therapist, but then once they get there, what happens? They become the biggest believer.
Well, they never want to leave, and so we have to tell them, your insurance has run out or you've reached your goals and it's time to kind of transition back into your own program. And so they begin to negotiate with us to stay on a little bit longer. And, if we can find appreciable goals, we consult again with the physician to maybe step up the goals. And then but yes, the people that are initially cynical become the biggest believers. It's often the case.
Usually the proper frequency for therapy is about 3 times a week.
It depends upon the patient, depends upon the severity of their issue, but 3 times a week is a good beginning, and then gradually diminishing to twice a week, once a week, and to kind of transition them back into their own program.
As a joint replacement surgeon, having performed well over 2,000 total hips and 2,000 total knees, I have an army of aging individuals who come back once every year or so to have x-rays and have their total joints checked. And as they're there, I watch them walk and move and say to some of them, particularly the older ones, getting up into their 8th, 9th, 10th decades even, that perhaps it's good for them to go back for 6 or 8 weeks every year or two for a refresher to sort of recondition themselves. It's certainly harder to build up strength than it is to maintain it. What I most want to stress to the viewing audience is that physical therapy is a rigorous and controlled academic discipline and profession, but in the ideal circumstance, the physical therapist, of which Dr. Richard Giordano is an example, works as part of a comprehensive team for patients of all ages, young and old, and it was our goal today to reach out to the audience and teach them a little bit about that. So I want to thank you for coming in,
Thank
Richard.
you, Dr. Seebacher, for inviting me.